pharmacogenetic testing results. I'm going to use a few examples. Mr. Smith is a 70-year-old male with a history of depression. He's failed 2 antidepressants in the past, and so his provider orders pharmacogenetic, or PGX is what it's often referred to, testing to help further guide the medication change. And so when we get the results, we see that there's no gene-drug interactions with current medications or medications that are considered for treatment. And the reason we want to look at this is a lot of times people think with the genetic testing that it can't be beneficial. There are times where you do see this result, and it doesn't impact your decision-making, it doesn't personalize the medicine for the patient. There's a 2022 study from Pasternak et al. It's cited in our presentation if you want to look at it, that evaluated the prevalence of prescriptions with pharmacogenetic guidelines and the occurrence of gene-drug interactions, DGIs. And the findings included that there's a prevalence of PGX prescriptions. 75% of patients had a prescription for a medication with a PGX guideline. The frequency of the drug-gene interaction was up to 60% of patients had at least one drug-gene interaction when considering genotype-based recommendations to adjust or monitor therapy. And almost 25% of patients had more than one unique drug-gene interaction, and among these, 61% of patients had a DGI involving more than one gene, which highlights the importance of how genetic testing can help with the personalized medicine. So when you look at this result, we like to look at what are the next steps? So we're going to follow evidence-based guidelines. The impact of this test was no significant findings. The benefit doesn't necessarily outweigh the cost of testing, but like we talked about, that's not actually the most common result when you end up doing the genetic testing. Same example, same patient, but what we see is that the results show a moderate gene-drug interaction noted with current prescribed medications and considerations for treatment. So when we look at what are the next steps, we're going to review the results, examine the findings, and follow evidence-based practice guidelines. And the impact of the testing can be clinically significant results. The benefits outweigh the cost of testing. We're going to go into some specific patient examples that show, but the results of these tests don't necessarily always mean that the patient has to have a change of medication. There are considerations that you would keep in mind. So I always like to say that because you're still going to review the results, examine the finding, and then in combination with understanding how the genetic profile can impact those medications, you're still going to utilize a combination of that and evidence-based practice. And the third scenario is significant gene-drug interactions noted with prescribed medications. And so, again, it's the same. You're going to review the results, examine the findings, and follow evidence-based practice guidelines. So clinical indications for pharmacogenetic testing. There's actually limited clinical practice guidelines on this across the spectrum of healthcare, but especially for psychotropics. That's what we're talking about today. This is from the Mayo Clinic Center for Individualized Medicine, and it was noted in 2023. So they list the indications for pharmacogenetic testing as the symptoms can be suggestive of drug metabolism concerns, toxicity or adverse reaction, and there's some examples listed there. Efficacy issues, so for example, this is for a medication that you would use to treat pain, but it also applies to psychotropics. So if the patient's not feeling like the medication is working for them, is the efficacy. Medication non-compliance due to unwarranted side effects or lack of efficacy. Self-adjustment of medication, dose or frequency in the outpatient setting, or actually in post-acute care AL setting if the patient's giving their own medications. You do see that, where they're like, I just decided to take 20 milligrams of my Lexapro instead of the a 10 because it wasn't working, right? That's an example. Prescription of a medication with a known adverse drug effect, patient desire for testing. And so this is, again, probably the most guideline that's out there to follow, and it talks a lot about all of the reasons why you would consider doing a test on someone. So I think it's important to note if the patient desires it, we should allow it. But also you see there prescription of a medication with a known adverse drug reaction. And that comes to your question of is this required if there is an FDA label. It is not, but they are suggesting that you should to prevent giving a medication at the wrong dose, at least, or in general, to a patient who may have this gene-drug interaction. So practical considerations, what are people who are utilizing genetic testing seeing? I think in the post-acute care setting, we definitely see a lot of polypharmacy. We are always evaluating if we can, do a dose reduction on a medication that a patient's being prescribed. You can have patients who have a failed response to multiple psychotropics and risks of delayed efficacy in treatment. And we'll go into this a little bit more in some of the case studies, but when we're treating patients with polypharmacy, we often will see them taking multiple medications in the same drug class. So if I'm a provider that's like, hey, I don't really think, and I am a provider by the way, but if I'm a provider and I'm like, I don't really think this patient should be taking 3 antidepressants, without the use of this test, I'm just selecting one based on a history, their recollection of, did this medication work for you? Why was it started? What was your response? Do you feel like it's still working? And I'm just gonna blindly select a medication that I think I should take them off of. Same with the GDR evaluation. Failed response to multiple psychotropics. A lot of times in mental illness, and mental health in general, in any setting, patients get discouraged when you try to treat their symptoms and continuously give them something that's not working and or causing them to feel very horrible. So giving them a medication that we're sitting there saying, I'm gonna prescribe you this antidepressant, you're gonna feel better in 6 to 8 weeks, and now they have, horrible GI issues, and they don't feel better in 6 to 8 weeks at all. That can be really disheartening to them, and it can also prevent them from really seeking further treatment. And then the risk of delayed efficacy in treatment. So if we have something that can tell us this is gonna likely be the most effective medication, or at least look at the class that we're prescribing and say, hey, we can't tell you out of these ones which will be the most effective, but these ones won't be most likely, right? Or they're gonna cause negative side effects. Looking at that can help us get patients to be treated faster. Okay. So we have another case